So, welcome everyone. Good night. Good night. It is another She Merge podcast. Tonight, we will be speaking with Dr. Renee Clark. I am Kimberly, and I am the co host, and our host is Sophia Rose. So, let's dive in.
Welcome, everyone. Thanks for joining us today. And we are so excited to be here, and because we know that tonight will be very extra special, because not only that, we have Dr. Renee in this space. And so I will go ahead and read Dr. Renee's bio before we get into it. Renee Clark, DNP, APRN, was born in the island of Jamaica, where she grew up in a small fishing village called Old Harbor Bay. She grew up, yes, in Old Harbor Bay. Her early years were spent at the Marley Mount Primary School, where she had her formative education and then went on to study at the prestigious Wolmer's High School for Girls. She graduated high school at the tender age of 15, where she majored in sciences and a minor focus in the Spanish language. She's bilingual. She is bilingual in English and Spanish and also has a knack for conversational French. After relocating to the United States over 21 years ago, she enrolled in Nassau Community College, where she completed her associate's in nursing degree. During her time in school, she worked in the capacity as a nurse's aide on the weekends and a bank teller during the week. Renee officially completed her nursing degree in May 2006, after which she relocated to Texas, where she pursued a role as a labor and delivery nurse. She obtained her bachelor's degree in nursing in 2009, a master's degree in nursing education in 2012, and a second master's degree as a family nurse practitioner. She completed her doctoral studies summa cum laude with a 4.0 GPA. The focus of her doctoral thesis was on mitigating the implications of obesity in the African American community. Renee is the owner and vice president of Dicel Health Management Consultants, LLC, a healthcare company she formed alongside her husband, Kevin Clark, who she has been married to for over 19 years. The company's vision is to disseminate educational tools to improve the lives of members of the local community. Dicel Health and Wellness is located in the busy commercial area of East Fort Lauderdale. The company offers primary care, women's gynecological health, hormone optimization, medical weight management, IV hydration services, telehealth, and concierge services. Dr. Clark is one of the preferred specialists in her area that is partnered with Sotoplay, a company that offers bioidentical hormone pellets for men and women. She is a skilled provider for IUD insertions, Nexplaluns, lipo injections for weight loss, consultations, visit, which allows patients to spend the time they need and not feel rushed during their visits. Dr. Clark has recently partnered with Barbados Fertility Clinic in Barbados to provide services for their clients seeking IVF treatments. With over 18 years in women's health, she has an excellent vantage point as it relates to guiding patients on their journey through fertility treatments and high risk pregnancies. Her office is able to offer on site IV hydration treatment for pregnant women suffering, yes, and at a discounted rate at that, in comparison to urgent care centers or other walk in clinics. Her goal is to collaborate with other team leaders to close the gap and eliminate the disparities that exist within the healthcare industry by increasing access to care, decreasing cost, and ensuring primary prevention educational tools are accessible to all. She is a global speaker on topics related to women's health and is actively partnering with churches across Europe, North America, and the Caribbean to add health related ministries to their overall services. Renee has certainly health matters that are near and dear to her heart. She is tenacious about improving outcomes in the Black diaspora through education and ensuring that Black men and women know their health matters and their concerns are valid. She is dedicated to provide representation for members of the diaspora and empowering others to place value on their health in a holistic manner. Ladies and gentlemen, locally and globally, I now present to you our speaker for today, our honored guest for today, Dr. Renee Clark.
Thank you, thank you, thank you. She emerged. I'm so happy to be here with you guys tonight. And I am hoping, I don't know how much time I have. Is it like an hour or? Okay, perfect. I am hoping that I'll get to cover quite a few topics here tonight. We're going to start from the beginning and we're going to work this thing in a chronological order. We want to make sure that we are covering every girl, every woman of an older age, whatever place you fit in, we're going to try to cover your health related issues and, just give you some tips. I can't go into a lot of details tonight, but I am available for consultations. So, Lady Sophia will be able to present you with that information. So,
Absolutely.
I would like to start with a prayer. Father, I thank you tonight. I thank you that you're always present and you hear us before we call. I am absolutely nothing before you tonight, Father. I'm asking you that you will empower me with the right words, the right teachings for the individuals that are present here tonight. Many have joined from different places, coming in with different needs. And Lord, I cannot meet their needs, but you are well able. Bless us here. Give us the grace to just execute that which you have laid on our hearts. And when we're done here tonight, we are going to be feeling so good that we were in your presence, but also addressing our physical needs. Thank you for hearing us always. In Jesus' name, amen. Praise
Amen.
God. So, I am going to start off with the young ladies. A lot of times we are getting older, and many of the things that we find out in our mid 20s and 30s, if we had just addressed them on an early basis, really, we wouldn't have to suffer as much, right? I grew up in the Caribbean, I grew up in Jamaica, and I realized that many of our Caribbean and African Americans as well, they do not like to talk about their health history. And the women also don't really talk much about their sexual health until you are sort of experiencing a little bit of what they have gone through. So I don't know about you ladies, Kimberly and Sophia. When I had my first menstrual cycle at 8, that was precocious, right? I think maybe at that time, had maybe my mom been more aware, that could have been a gynecological visit where she could have had someone intervene, stopped those periods because they were way too early, and give me some quality of life. Can the church say amen? Because 8, right? How do we manage that? No, as many of us being mothers, aunts, we're godmothers, We are seeing our little nieces or cousins and so on. They are now getting to the place where they're starting their menstrual cycles. I am hoping that we are doing them the justice that we were not given. And we're not knocking parents because they weren't given anything either. So they had no tools in their tool bags to give out. We are now looking at it from a different vantage point. We have a bunch of tools and we're going to make sure you know how to use them. So menarche, starting the menstrual period. On average, we're looking at the age of about 13 on average. But like I said, kids like me who wanted to be hurry, right, had a period at 8. And you do have some children much younger than that. And we really want to stop that because that is not normal. So, the point I'm trying to make for our parents, be responsible about the gynecological health of your daughters. If you have a daughter who maybe she hasn't started her menstrual cycle yet, this could be a good time to introduce her to a GYN provider. And you're saying, well, why not wait until the period starts? I have realized we have been very reactive as a society. We have not prepared for anything. We wait until it's here and then we're scrambling to try to figure out how do we do this. So, those early conversations with a GYN provider that you trust, maybe yours or someone else's that they came highly recommended, you can bring that child in and let them start asking some questions because growing up in Jamaica, we had words for our anatomy that just do not make sense. And to this date, some adults do not know the proper vernacular to use for their body parts. Let's just be clear. Some adults still do not know their actual anatomy, even as women with 3, 4, 5, 10 children. When you're saying to them, you're putting in a catheter in their bladder, they ask you, so how is the baby going to come out? Your urethra, you're trying to hope that by this time they would have some knowledge, but we're here to change that tonight. We just want to make sure we're all on the same page. So bring them into a GYN provider and have them ask the questions. That is where they're going to learn the truth on the anatomy and physiology, just the basics that they need to know that, matches their age. So if you're looking at a 13-year-old, believe it or not, she is going to find out. How do you want her to find out? Do you want her to have information that is solid, that is, evidence based? This is actually what it is, versus just what some random person told her, what her bestie said in class. We want to give our children the tools that we did not have. So, if your child started a period very early, and we call that precocious puberty, you want to intervene, parents. 8-year-old is like that age that we say is precocious. And like I said, you might have one or two outliers who might be a little earlier, but guaranteed at 8, we want to shut that down and wait until the child is a little bit more developed, right? No, we were born with all the eggs we were ever going to have. So can you imagine at 8 giving away those eggs for free every month? Like, come on, I'm gonna need these in my 30s. You know what I mean? So that is the premise behind just kind of getting that, squared away. Now you're in your teenage years. Body is bodying, and life is lifing already for many of us, right? We think we know it all, and we are doing the most because, we have the lip gloss now, we have the tablets, we have the cell phones, we have it all, and we are just living life. Well, here comes some other challenges that you're hoping, if you had a gynecological visit early, that this could also be addressed. So the menstrual cycle, what that looks like, and also talking about the risks for sexually transmitted diseases. Very big one. A lot of teenagers are at risk for especially gonorrhea and chlamydia. Those are two of the common ones, and of course, the human papillomavirus. And while I'm not here to preach vaccines and how to raise your child, there are some preventative things that you can do. Vaccination for HPV is there. It's a series of three, and you can talk to your healthcare provider a little bit more about that. Now, STIs, untreated in this population of children, you find that in the 20s and 30s, when women are experiencing issues to conceive, when we're doing the workup for them, you find a lot of scarring on the fallopian tube. And the reason for that is untreated pelvic inflammatory disease, which most times, those two, those are the culprits. So, can you imagine you didn't really bring your daughter in or your niece and have her have a real conversation about what STDs are and why she should protect herself. And I know we're all caught up, we're all saved and sanctified, but let's just be real. We live in a real world with real life things happening. And what we do not want to do is to do what the forefathers did by not addressing it. Not addressing it is not going to let it go away. It's going to perpetuate. So we need to address and have a plan of action in place. And this is where people like me come in. If you don't feel like, hey, I can't afford this gynecological visit that this person is talking about, but I'm a member of a community, whether it's a church community or a girlfriend community, and we all could put a couple dollars together and bring this speaker in and let her talk to the kids. That is another option. In the churches, you have a lot of youth ministry, but in the youth ministry, I don't see where we're introducing them to anything medical or anything addressing the physical aspects of their bodies. We have spiritualized everything. And believe me, we love that part. But we also have to admit that we're not just spirit. We are literal flesh, and we have to actually address the needs and the concerns that we have. All right. So those teenage years are going along. If the children become sexually active during that time, this is a time where, you can experience things that you really don't want them to experience. However, if they have the knowledge and the tools from the right sources, many times these children know how to protect themselves. There are going to be the few outliers who are going to test the waters and do what they want to, but have an open line of communication. And I was saying to Lady Sophia earlier that sometimes the very first way how you respond when the child comes and says, Mommy, I kissed the boy, you better put that poker face on. You better press down on the thumbtack in your shoe and don't make a sound, because I know you want to blow a casket or a lid, but this is not the time. Your response in that moment will probably be that benchmark for all the responses that child is going to see and feel going forward. Your response in that moment might distinguish that child from the one who needs to sit in therapy because that parent went off and they literally now have a strained relationship. What we're trying to do is to move past those negative stereotypes and bring children into a safe space. They are yours to pay rent. And while you are paying rent for them and you have been loaned them, you want to ensure that you are doing your due diligence. You're not going to have all the answers, and we don't expect you to. But ask your good girlfriend, man, where you take Michaela to. Is there another person that she went to talk to? I know she's like this age now. Is she doing this? And share with your girlfriends. This is not the older age time in the 50s and 60s where there were no phones or WhatsApp. You have no excuse. Build a solid community around these children so that they can see and mirror that same behavior. Because a lot of times that's what they're going to bring outside, what they're seeing in the home. right? And you want to also not just leave it to the professionals, but also when they come back home, what did you understand from what so and so said today? Did you have any questions? Or, I don't want to make it weird for you because I know you know everything. And you meet them at the point of where they are because that's exactly how they feel. They don't want to talk to you. And also, you want to make sure if you do take them to the GYN, for example, sign the consent form, and mommy will sit down outside or daddy will sit down outside and give that child a little space with that provider to have
Mm,
that one-on-one conversation. I know you want to know all of what's happening with her, and you do have that right. But I also want you to create some boundaries. And she's going to create some boundaries, and you guys are going to figure out how those two things are going to mesh. And that's individual. That's going to be very different for every household. But establish that very early on. That's what I'm saying. So here
mhm,
we are at age 21, and we're going up. Age 21 is a fun age because it is the age where no matter how sexually active you were or not, this is the age you get to have your first pap smear. Not your first pelvic exam necessarily, because if you were sexually active and going in before, you would have had pelvic exams. But this is the age for the pap smear. And what in the world is a pap smear? And why do older women fear the pap smear and fear the gynecological visit? What is it about this visit that has created mistrust and trauma for older women? Let's talk about that. One, at 21, a lot of our parents did not know that that was the age to take us in for our pap smears. So we did not find out about a pap smear until some random person was talking about it and you sat there nodding like you knew, and then you went on Google and you saw some stuff and you're like, no, I'm going in no for this. You just look for the closest in network provider. You didn't ask anybody, hey, you have somebody good, or is this person recommended? You just looked at your insurance card, this one, and you went into somewhere without even really researching. We don't do that anymore. We want first-hand knowledge of people these days. And I know Yelp and all these reviews and all of that matter, but I think the first-hand knowledge is a big part, not just some random person. So you go in for the pap smear and the room cool, they give you just a little, just a little thing for cover up, and you're just like, my goodness, why is it so cold? Why have I been here for 30 minutes? My goodness, it's been an hour. And you're sitting there in a cold room by yourself most times, or if you had a sister or your partner with you, and you're just there waiting. And this is kind of not really what I had in mind. And then someone runs in and she says, put up your feet. Wait. What happened? Put up your feet, stirrups. And she just touches the stirrups. And you kind of put your foot, and she's like, you got to scoot your bottom down. Okay. And you're scooting, and then it's just business. Boom. Any questions? All right, I'll get you your results in a couple of days, and we will talk. And then you didn't hear from the office, so your assumption was, I guess I'm good. They didn't call me. So that's a good thing, right? I mean, right? We don't do that. We don't do that anymore. There are, of course, going to be the outliers. What our office has tried to do is to make this experience one where it's a traumatic. First of all, you're coming in on an appointment basis. There's not three people booked at the same time that you are booked. You have an entire hour with your provider for yourself. Once you enter the office, you are right away brought into your room. Just make sure you had filled out all your paperwork before. So you don't have to sit there for 30 minutes filling out paperwork. That's 30 minutes out of your 1 hour visit. And we really do try to keep you for that 1 hour to make sure that you understand everything. So then we're going in and we want to talk to you before we just let you take your clothes off. We want to make sure that are there any traumas that I need to know about before I put my hand on you? I have asked women every single time, are there any gynecological traumas or any mental health issues in the past or current that might be a trigger when I actually, or be triggered when I touch you in this area? And I've had women in their 90s and young women, all ages in between. You're asking my permission? Yes, ma'am. We're supposed to. You don't just lay hand and touch someone just because that's your job. You want to let persons know, I see you. If you did have that trauma, please let me know if there's anything that I am doing that could be a trigger. Because the last thing I want is to create this trauma at 21.
You
Because guess
traumatized.
what happens for the rest of the time? Homegirl not coming back. And she's still sexually active. She's still at risk. She wants to have a baby. Life is going to happen. And she is no longer going to have the trust in the system that was built to protect her. We do not want that anymore. So we're talking to individuals about what this visit should look like. And we might just come in for 5 minutes and tell you, hey, so we're going to do this and this and this. Those are the typical things that we do. But are there things that you'd like to discuss before we get into the physical exam? Because we don't want to just jump into the physical exam. Those of us who are married, we know we want to preheat the oven before you stick in the turkey. Like, hello, buy me a drink. Not really, not really. But you know what I'm saying. Like, don't just jump in. Have that conversation and let your patient feel comfortable. And this eye contact thing, it's important. This computer thing while your patient talking is a no-no. So you want to make sure you're watching and seeing how am I engaging with my provider? Is she listening to me? Or is she putting in last for the patient next door? She just came in for like 2 minutes, and I get it. I've worked those busy offices, but it does not take away from the fact that I still need to address you as the person. For whatever time I have with you, 15 minutes, 20 minutes, you are the priority. So, Pap smear. This is where we're checking the cervix, which is the neck of the womb. And we want to look at it under a microscope. So we collect some cells, we put in a speculum, and we take a look at everything. Even though we're just doing a collection of cells from the cervix, I want to see what the entire, pelvis looks like on the outside. I want to see is there hair on the mons pubis? Are there bumps there? Are there abrasions? Are there bruises in between your legs? When I actually touch you to do the exam, are you experiencing discomfort? Is there discharge? If so, does it have an odor? What's the color? All of those things are going to matter. And then when I put the speculum on the inside, how did you respond? Did you tolerate that exam, or did I have to switch out to a pediatric speculum even though you're 40? You see what I'm saying? So we're working with the patient and making sure that this patient is feeling safe at all points of this and exchange. Then when we are actually there looking and we're collecting our sample, we're trying to be quick, we don't want you to be uncomfortable. We're looking at the walls of the vagina because we want to make sure that there's no abrasions on the wall. There's no type of discharge that's attached to the wall that looks a little weird, and we might need to take that and send that off. If there's a yeast infection or bacterial vaginosis, we want to treat that because that can be pretty uncomfortable. And then, are you at a stage where we're looking and we're seeing atrophic changes, meaning that things are shrinking down, looking closer to 60, but you're in your 20s? That's an abnormal finding at this age. So we're going to need to have some evaluation of this because this is not what we expect to find. So we're doing the pap and we're doing all of that at the same time. And during your well woman exam, which you can start it at 21 as well, you are getting a breast exam. Ladies, October is celebrated as breast cancer awareness, and January is cervical cancer awareness. I don't want it to just be during the months when things are celebrated that we are aware of them. Breast cancer can happen at any age. Breast cancer can happen to any gender. Montel Williams was probably one of the first men who came out with triple negative breast cancer, one of the most aggressive types. And he has been very outspoken talking about it for years. Other women, of course, I've seen women in 18, 19, 20 years old. Of course, that's not the typical person. It's usually a disease of the older person. But I want you to do your breast exams. Don't just do it when you come to the office, even though we will do it during your well woman, but learn to do them. And I can't do that tonight because we're kind of running through. So you get a breast exam. We're also going to check under the armpit because that's part of, the tail of the breast tissue. So we want to check that as well. And what's going on? Are you chronologically matching up with where you are physically? That's another cue for your healthcare provider. Because if you are 21, 22, we expect you to be, and we call it Tanner stages, we expect you to be at a Tanner stage 5. I am not expecting to see a Tanner stage 2 where there's no breast and or breast buds. We shouldn't look like that, right? So that brings into question, are there genetic abnormalities with your patient? But if you never identified this very early, can you imagine getting married in your 30s and then being told, sis, you don't have the parts that are necessary for procreation? Houston, we have a problem. This is why we're saying preventative. Come on in before there is an issue. So pap smears in the 20s, we try to do them every 3 years, but you should have a pelvic or a well woman exam at least once per year. Don't skip it. Don't skip it. And let me just say this. If you're sexually active, whether you are married or single, you need to have sexually transmitted disease testing. It's not a question. I'm stating facts, whether you're married or not. You need to make sure that you are always in charge of your sexual health and you are never leaving that in the hand of anybody else. I don't care which bishop, I don't care which archbishop, tell them I said it. And I did. Get checked once a year, minimum. And if you feel like there are reasons for more frequent testing, then make sure you go for that. If there's symptoms going on, discharge, itching, burning, what we're doing here, we're going to go get checked. So have a good relationship with a good provider, because in your sexually active years or this time of your life, you're going to be in there quite often. Just saying. All right. Okay. So we're at age 30. This is a fun age. I like 30. I like 30.
Yeah.
I like 30. We call it 30. 30 very fun. 30 is like, all right, girl, I'm still young, and we're still gorgeous, right? We still have the 20s weight for the most part. And know that we're in the 40s, we're hoping to be back at the 30s weight again, all of that. So 30 is a nice prime age. Many of us have probably finished school by now if we've gone to college or decided that that was the path we wanted to take. Many of us by 30, we're like, all right, I think this is probably time that I really settle down with a partner because you've been dating in your 20s, and we kind of encourage that. Don't lock down with anybody right away. Like, know what you like, know what's out there, because all of it is not for you. And maybe that one person who matched you at 20 is not necessarily who will match you at 30. I am just saying, take it or leave it, right? So 30 is a fun time. You are now focused on dating with intention. And this simply means that, listen, girl, now what pattern where you stress me is either you do this or just move on. So you're dating with intention. Make sure that if you are dating and you are sexually active, again, somebody needs to bring his papers while you're bringing your papers. And we need to see papers and make sure things are okay. And we need to protect ourselves, of course. I'm a big proponent of that. But I'm also saying make sure you're seeing somebody's papers because people are playing these streets with people's lives. Okay? Don't let anybody play with your sexual health. You are always in charge. Bring your own condom if you're sexually active and you're single and doing your thing, whatever that looks like. Bring your own condom. Okay? Well, say bring your own beer or bring your own condom. All right. So at age 30, we can now start co-testing essentially. Not just doing the pap smear, but we're checking actively for the human papillomavirus. We kind of don't do the co-testing in the 20s because if you're sexually active, we expect that you're going to have it in the 20s. But by the time you hit 30, 31, the anticipation is that that immune system is just nice and robust, so it's going to clear that virus. So by the time you hit 30, we're hoping for a negative HPV test. If it is positive, we're going to want to address it based on what your pap smear looks like. And of course, I won't get into the intricacies of that, but that can also impact what fertility looks like for you later on. All right. So very important. Get that pap smear, get that HPV test co-tested by the time you hit age 30. Now, we have always been of the school where, again, very reactive. We didn't go very early, so we didn't have early conversations. I used to be in San Jose, California, and I worked in Los Altos, which, is a nice little affluent town, about 20, 30 minutes outside of San Jose. And Stanford University is pretty close to that area. So I got a lot of people from Stanford because once one person went and told the other person, all of a sudden my schedule was filled with a whole Stanford class of people. Even the guys were like, "Do you see guys? Not here, not here." It was just really funny. But I liked that. I really enjoyed that population. And I sat down and had real talk with them because listen, this is not the time. We're getting one chance to do this, guys. We don't get a do over. So if we can impact and mold and do it the right way the first time, we would be happy people just living our best life, right? So I would sit and talk to them and I would say to them, hey, have you thought about, having children later on? And some of them, they're like, I'm 21. All right, no problem, sis. I was married at 20. Okay. Next one. And the next one would say, yeah, maybe like at 25, because I'm going to have my doctorate. And, they're in that age group, and you love them for that because they still have hope, not us, right? Just teasing. But they are so receptive to that information. But the reason I bring that up, a lot of times during that time, it would be a good time for them to start talking about egg banking. Because as I mentioned before, we're born with all the ones we're ever going to have. So in your early 20s, those eggs are nice. They are prime. And sometimes some of us have some excellent jobs, with some insurances that are like a Rolls Royce, sis, right? This ain't your regular Blue Cross. This is the Rolls Royce Blue Cross, okay? And you could actually get egg banking for a nominal cost. I'm talking about a $20,000 procedure for just a little copay. Take
Mm-hmm.
advantage of save those eggs, especially if you have no interest right now and you don't see yourself having any interest any at all. Have that conversation with your GYN provider. So by the time you get to 30, and maybe you might have met someone, gotten married, and then you're trying to have the baby, and 6 months pass, and you start getting nervous, and then you hit 1 year, and they said, "Oh, 1 year of actively trying, and you didn't have a baby. No, you gotta go to the specialist." Oh my gosh! Imagine if you had those eggs. The apprehension wouldn't feel so bad when you're told that you have diminished ovarian reserve at age 30. Wait, when say? When say me diminished? No, say me not short. Like what? What does that even mean? And you are just thinking along the lines of, I am 30. I
Mm-hmm.
just turned 30. What do you mean? Well, guess what? It's your luck of the draw. You were one of those with the period at 8 that never got stopped, and here we are. Life just dish you dirt. We can try IVF though. We're going to work out some things, but you might need a donor or you might need to adopt. And it's like, wait a minute. My whole entire fertility has been decided here right now. It's a big thing for you to actually swallow. Big pill to swallow at that age. So that is just 13. We don't even reach over 40 yet. When you're actually over the advanced maternal age and know things are like, oh my, listen, I need this to happen now, or it's now or never. Because you know what I mean? Okay. So egg banking, and also just making sure that you're still following up with all the things I had said before. Age 35 is that like the midway point. After 35, we call you advanced maternal age.
Mm-hmm.
Elderly pregnancy, if it's the first one, primigravida, multiples, multigravida, but it's called elderly. I loathe that term. I am not elderly, thank you. 34 is girl nice and clean. What you talking about? So I like, you know, that time frame where you're just thinking, okay, all right, we've been doing this thing. And if between 30 and 34, you were trying actively to conceive unprotected intercourse for an entire year, well, guess what happens at 35? That year gets shortened down to 6 months. No, it's after 6 months that you actually have to see the specialist, not 1 year anymore, because you're clearly needing some assistance.
Mm-hmm.
Assistance can vary. Assistance can vary from, sir, this goes into this. Understood? Oh, you've been doing it wrong. That's basic assistance, and everybody is happy because they get pregnant next month because they're doing it the right way. Or assistance can look like, all right, so what we're going to do, we're going to give you a little bit of letrozole, that's a medication, or Clomid, another medication. We're going to stimulate ovulation, and then we're going to give it to you on these dates of the month, and then you're going to try on these dates of the month and just have a lot of sex. Just go, go, go. Like, I have to work 2 jobs. How we go? Okay. Now, how much cycles of this I need to do? Well, your insurance is good, so we can do a few cycles. And the pressure is unreal. The pressure on the women, that is unreal. Because a lot of times we automatically assume that if there is an issue, it is ours. when the studies have naturally shown that is truly 45, because there's a 10% of unexplained infertility. So both of us could potentially have issues. And we don't even deal with the man then yet. This is just a women's night because they have stuff too that we need to address. But call me back. All right, Sophia? Okay. So here we are talking about just IUI. That's one thing. Other things, if the IUI doesn't work, they'll do timed intercourse. Other things, they are going to literally say, maybe we're going to send you to a reproductive endocrinologist. So this is where they're pulling out the big guns. Some of those do IUI as well, and they can get you pregnant very quickly. But if you're being sent to REI, is what we call it for short, yeah, this is where the babies are either going to be decided for the most part. You're going to either make them or you're not. Very seldomly you'll hear, oh, I went to go sign up for my IVF visits and I was pregnant. Okay, bless the Lord for you, sister. Yes, I'm happy for you, but like this is my 10th cycle. And you want to be so understanding of the person who got it on the first shot. But here's Sister Mary, who has been struggling for 20 years, sitting and talking to you right here, right now, right? It's my real life issues that sometimes I'm like, okay, why did I have to go down this path? Because I don't love it. I don't love this path at all. But it gives me such a vantage point and authenticity and just my transparency and relatability with my patients to sit and say, sis, it's not just you alone. The mental health part of that, the all just always thinking, is that the period? Oh no, that feels pregnant. Jesus Christ, another period. You're just done. You're over having these cycles. It's just way too much. And we don't even want to talk about the mental health of what that does to a woman, how that diminishes your capacity as a woman and as a wife, how that causes you to no longer really relate as much to your spouse because you don't really feel as complete. Now, talk real things tonight. And if the men were to also be honest, they would also say the same thing if they were the one who had the issue. And then you have two people here who one is thinking, well, maybe I can just do this and we don't have to stay together. I could just go get a child outside. And some marriages have that happen. And what do you do when you are the one who could not conceive and hubby gets a baby in the first month with Sandra down the road? Does it put Sandra? What? No, can't be real. Because in your eyes, Sandra does not line up to you at all. She can't even walk in your size 9.5 Louboutins, sis. What? And Sandra is who he got pregnant? No, block road and burn tires. Right now, we are protesting that. But that is reality for a lot of women and men too, because women also do the same and they will step out. What do you do when those parts come into your church homes? How do you relate to this situation where wife is standing here, Sandra is here, and the man standing here with the baby and just hoping that nobody breaks fight at the baby's christening? That's a real thing that happens more often than you know. So we want to deal with anything that could potentially lead to any infertility issues very early on. So identifying menstrual irregularities when they just start. Yeah, in the first 2 years when a child just starts a period, we expect the irregular periods. But once you've been established, 16 and above, no man, that child should have a regular menstrual cycle. We call it like a clockwork cycle. Anywhere between 26 to 31 days, somewhere there, so. And for some of us, 28 days at 12 o'clock at night. If it's 1 o'clock, no, something wrong, right?
Mhm.
Some of us are so regular. So if you realized that that child had a period in January and didn't get another one till July, and then it was December before she had another one, only 3 periods, and she had some regular ones before, that is a red flag. And because you have already cultivated a nice gynecological relationship with a person that you trusted, you could bring her in and the workup could be done and early intervention could happen. She will have a diagnosis and she won't have to wait until she's 40 to be told, you have PCOS and you may not conceive. I thank you. So here
Wow.
we are. Talk to me, Lady Sophia. Let me know how much time I have.
9 minutes.
9 minutes. I will wrap it
Nine.
up.
Are
I will.
there any questions in the chat? That was
There,
real.
there are no questions in the chat right now. I was hoping that our avid viewers, I see that we have a few viewers, but I wanted to ask you a question, and I'm so glad you
Mm-hmm.
brought up PCOS.
Mm-hmm.
What are some of the treatments for PCOS? Because I realize you brought it up speaking about learning about it in your later life, not
Yeah.
necessarily when you were younger. What are
Yeah.
some of the treatments that you would suggest for women with PCOS?
First of all, have a diagnosis for it. That's the first thing, right? At least get some baseline blood work to just see what are some of the challenges you're having. Do you have a high level of androgens that are just floating around that you are going to need to address? Because those androgens can cause different symptoms for women. Now, when you say treatment, you are thinking about, does this person want to have a baby right now? Or is this a younger person who, you know what, we can put her on some birth control and just make sure that that lining of that uterus, sheds and we're okay. So it depends on the goal of the patient. If the goal is pregnancy, then I don't want to put you on birth control. We might do that for a short time, but I actually want to regulate that cycle. So we might try the letrozole, we might try the Clomid, and then do the timed intercourse, or we might go up to IVF. But weight loss, lifestyle changes,
Mhm.
exercise, diet, sunshine, vitamin D. I mean, all of those you cannot take away from those things. Primarily, that is your treatment for almost everything. Good gut health, good environmental exposure. Those are your treatment for almost everything. Because what really does cause PCOS? Still, the jury's out.
Wow.
Age
That is
40,
so profound.
breast exams and mammograms.
Mhm.
40, we're starting them or starting the discussion.
Mhm.
One body of evidence says have the discussion, one body says start it, but definitely by 45. Let's get that done. It can be done annually or every 2 years, but it depends. Are you somebody high risk because mommy, grandma had it? Or are you someone of average risk where nobody had it and you're just going to get randomly checked?
So,
That will determine how often and how your checks start and when your checks start. A little bit on menopause because this is my favorite topic.
Yes, I was about to ask you to touch briefly on that because we're running out of time,
Five
sis.
minutes.
Let me
Five
tell
minutes.
you,
I'm
menopause,
gonna
that's
do it in two.
crucial. All
I'm
right,
gonna do it
go
in two
for it.
minutes.
Go for it.
No. Average age of menopause in the United States and Caribbean, 51.
Mhm.
But
Yes.
women can actually start experiencing some symptoms by the time they're in their mid 40s. And if you're precocious, puberty by the time you're 30s. We don't
Mhm.
like that. No,
don't
what
want
are some of the
that.
symptoms that you're talking about, Renee? I'm talking about the hot flashes, the vaginal dryness. You don't have a libido. What is that? Is that something you put on your food? You don't have that. You literally have to create that all the time.
Yeah.
But those are probably some of the big signs. But then when you look at the vaginal architecture, it is so thin that intercourse starts getting painful. So you're now wondering, are we catching a fire? Is this Sahara Desert? Like, what's happening? You're pulling for a lubricant that you never had to pull for before. All of these things. Some people get like a heightened sense of smell. They're always smelling either smoke or perfume. There are hundreds of symptoms, but we know these big ones. And how do we treat and why? Well, women have estrogen, progesterone, and testosterone that are made by our ovaries. And I know I said testosterone, and everybody's like, wait, she not have no sense. But yes, we had more testosterone than estrogen at one point. Anyway, as our body ages, it's the estrogen decline that actually throws us into the menopause. But
Mhm.
testosterone plays a good role as well, right? So we want to find a way to be able to replace these hormones,
So,
especially if you're a candidate to do so.
and Dr.
So,
Ren, we have
yes,
4 minutes.
that's it. Okay, all right. So if you're replacing the hormones, get some blood tests. Go
Yes.
to a hormone specialist. Sit down and have a conversation. Do you want a patch? Do you want a cream? Do you want a gel? Or do you want pellets that you can do just a few times a year? And I don't have to see you all the time, and there's nothing to remember to take. That's another thing. How's your sleep pattern in the menopause time frame? Because you're getting up to pee
Yes. Very
3,599
important.
times. That's a problem because you got a kid and you got to go work and you're a wife. And wait a minute.
Transitions.
Hello. So
Yes.
there's a whole lot of stuff going on at that
Mhm.
stage. And guess what also comes with this time frame? It's the sense of my life is done. It's
Mhm.
the changes in identity, the changes with the relationship with your partner, depression, anxiety, and all of those things start happening. And you're wondering, where did we go wrong? But we have 2.5 minutes. And
So,
yes,
Dr. Ren, as you mentioned that, I want to briefly say, and we're going to be off air pretty soon. Menopause is not a death sentence, right?
nope, nope.
It's a new
Natural
chapter that
consequence.
is starting, right?
Yes,
And
yes.
so there's still hope as women transition. So, to our audience listening, I want to encourage you. And at this point, if you would desire to reach out to Dr. Ren, you can drop a comment. And if it's a matter of privacy, let us know, and we will be able to give you her contact information. And so, with that, we want to say thank you so much for, being with us in this space. And we will, have another setting with Dr. N. This is not
We
over.
have to talk some more, Dr. Ren. There's so much to talk about.
So, we are
Yes,
so appreciative of your time, Dr. Ren.
no
And we know
problem.
that you are always welcome here. And
Thank
so,
you.
thank you again. Thanks, everyone. You
Good
have
night.
joined in this evening. We want to cover you, we want to encourage you. Get that wellness check done. Okay. Until our
Absolutely.
next podcast, good night. God bless.
Bye, guys.
Bye.